Welcome to Fertility Connected, and today we'll be discussing endometriosis and diagnosis and management of endometriosis in accordance to the National Institute for Health and Clinical Excellence for the United Kingdom. And the first part we'll be looking at today is the organisation of care for endometriosis. So set up and manage clinical network for women with suspected or confirmed endometriosis, consisting of community services, gynecology services, and specialist endometriosis services. When it comes to community gynecology and specialist endometriosis services, it's important that they provide coordinated care for women with suspected or confirmed endometriosis, and that they have processes in place for prompt diagnosis and treatment of endometriosis, because delays can affect the quality of life and results in disease progression for the patient. When seeking management for endometriosis, gynecology services for women with suspected or confirmed endometriosis should have the access to a few things, and these include a gynecologist with expertise in diagnosing and managing endometriosis, including training and skills in laparoscopic surgery, a gynecology specialist nurse with expertise in endometriosis, a multidisciplinary pain management service, a healthcare professional with an interest in gynecological imaging, and last but not least, fertility services. Let's now move on to the endometriosis information and support that should be provided for patients suffering from endometriosis. So specialist endometriosis services include and should have access to gynecologists with expertise in diagnosing and managing endometriosis, including advanced laparoscopic surgical skills, a colorectal surgeon with an interest in endometriosis, a urologist with an interest in endometriosis, an endometriosis specialist nurse, a multidisciplinary pain management service with the expertise in pelvic pain, a healthcare professional with specialist expertise in gynecological imaging of endometriosis, advanced diagnostic facilities, for example, radiology and histopathology, and last but not least, fertility services. Be aware that endometriosis can be a long-term condition and can have significant physical, sexual, psychological, and social impact for the patient and their families or partners. Women may have complex needs and require long-term support. Assess the individual information and support needs of women with suspected or confirmed endometriosis, taking into account their circumstances, symptoms, priorities, desire for fertility, aspects of daily living, work and study, cultural background, and their physical, psychosexual, and emotional needs. Definitely provide information and support for women with suspected or confirmed endometriosis, including what endometriosis is, endometriosis symptoms and signs, how endometriosis can be diagnosed, treatment options, and local support groups, online forums, and national charities, including how to access them for further information and support. If women agree, involve their partner and or other family members or people important to them, and include them into discussions regarding their care. For more guidance on providing information to people and involving family members and carers, view the NICE Guideline on patient experience in adult NHS services. So an important topic to discuss is endometriosis symptoms and signs for the correct diagnosis. So suspected endometriosis in women, including young women aged 17 and under, presenting with one or more of the following symptoms or signs can point to endometriosis. So chronic pelvic pain is one of many, along with period-related pain affecting daily activities and quality of life, deep pain during or after sexual intercourse, period-related or cyclical gastrointestinal symptoms, in particular painful bowel movements, period-related or cyclical urinary symptoms, in particular blood in the urine or pain passing urine, and infertility in association with one or more of the above. As a diagnostic tool, offer an abdominal and pelvic examination to women with suspected endometriosis to identify the following: abdominal masses and pelvic signs such as reduced organ mobility and enlargement, tender nodularity in the posterior vaginal fornix, and visible vaginal endometriotic lesions. If a pelvic examination is not appropriate, offer an abdominal examination to exclude abdominal masses. So the referral for women with endometriosis is the next step. Consider referring women to a gynecology service for an ultrasound or gynecology opinion if they have severe, persistent, or recurrent symptoms of endometriosis, or they have pelvic signs of endometriosis, or they have an initial management that is not effective, not tolerated, or is contraindicated. Refer women to a specialist endometriosis service if they have suspected or confirmed deep endometriosis involving the bowel, bladder, or ureter, which can cause further complications. Consider referring young women aged 17 and under with suspected or confirmed endometriosis to a pediatric and adolescent gynecology service, a gynecology service or specialist endometriosis service, depending on the local service provision. The diagnosis and the process of diagnosis of endometriosis is an important part leading up to the right treatment for the individual patient. So do not exclude the possibility of endometriosis if the abdominal or pelvic examination, ultrasound or MRI are normal. If clinical suspicion remains or symptoms persist, consider referral for further assessment and investigation. So when it comes to ultrasounds, consider transvaginal ultrasound to either investigate suspected endometriosis even if the pelvic and or abdominal examination is normal, or to identify endometriomas and deep endometriosis involving the bowel, bladder or ureter, or both. If a transvaginal scan is not appropriate, consider a transabdominal ultrasound scan of the pelvis. Do not use serum CA125 to diagnose the endometriosis. If a coincidentally reports serum CA125 level is available, be aware that a raised serum CA125, that is 35 international units per milliliter or more, may be consistent with having endometriosis. And also be aware that endometriosis may be present despite a normal serum CA125, so less than 35 international units per milliliter. When it comes to MRI as a diagnostic tool, do not use pelvic MRI as the primary investigation to diagnose endometriosis in women with symptoms or signs suggestive of endometriosis. Consider the pelvic MRI to assess the extent of deep endometriosis involving the bowel, bladder, and ureter. And also ensure that pelvic MRI scans are interpreted by a healthcare professional with a specialist expertise in gynecological imaging. Now let's look at diagnostic laparoscopy. So consider laparoscopy to diagnose endometriosis in women with suspected endometriosis, even if the ultrasound was normal. And for women with suspected deep endometriosis involve the bowel, bladder and ureter, consider a pelvic ultrasound or MRI before an operative laparoscopy. During a diagnostic laparoscopy, a gynecologist with training and skills in laparoscopic surgery for endometriosis should perform a systemic inspection of the pelvis. And this is to confirm the diagnosis of endometriosis or to exclude malignancy if an endometrioma is treated but not excised. If a full systemic laparoscopy is performed and is normal, explain to the woman that she does not have endometriosis and offer alternative management for her problems. When it comes to endometriosis, we have staging systems. So offer endometriosis treatment according to the woman's symptoms, preferences and priorities rather than these stagings of the endometriosis. When endometriosis is diagnosed, the gynecologist should document a detailed description of the appearance and site of endometriosis. As endometriosis is a long-term condition, monitoring for women with endometriosis should be taken with care. Consider outpatient follow-up with or without examination and pelvic imaging for women with confirmed endometriosis, particularly women who have chosen not to have surgery if they have deep endometriosis involving the bowel, bladder or ureter, or one or more endometrioma or endometriomas that are larger than 3 centimeters in size. When it comes to the treatment options for endometriosis, both the clinician and the patient can come to the decision between pharmacological pain management, non-pharmacological management, surgical management, and surgical management for fertility. So let's begin with looking at pharmacological pain management, and we'll first discuss analgesics. So for women with endometriosis related pain, discuss the benefits and risks of analgesics, taking into account of any comorbidities and the woman's preferences. Consider a short trial, for example 3 months, of paracetamol or a non-steroidal anti-inflammatory drug, alone or in combination for first-line management of endometriosis related pain. If a trial of paracetamol or an NSAID, alone or in combination, does not provide adequate pain relief, consider other forms of pain management and referral for further assessment. Neuromodulators and neuropathic pain treatments also come under pharmacological pain management for endometriosis. For recommendations on using neuromodulators to treat neuropathic pain, see the NICE guidelines on neuropathic pain. Hormonal treatments may also be an option. Explain to women with suspected or confirmed endometriosis that hormonal treatments for endometriosis can reduce the pain and has no permanent negative effect on subsequent fertility. Offer these hormonal treatments, for example the combined oral contraceptive pill or a progestogen, to women with suspected, confirmed or recurrent endometriosis. If the initial hormonal treatment for endometriosis is not effective, not tolerated or is contraindicated, refer the woman to a gynecology service, specialist endometriosis service, or a pediatric and adolescent gynecology service for investigation and treatment options. It's routine to perform laparoscopic surgery for endometriosis unless there are contraindications in the individual patient. So discuss surgical management options with women with suspected or confirmed endometriosis, and these discussions may include peritoneal endometriosis not involving the bowel, bladder or ureter, or uncomplicated ovarian endometriomas. As an adjunct to surgery for deep endometriosis involving the bowel, bladder or ureter, consider 3 months of gonadotrophin-releasing hormone agonists before the surgery. Consider excision rather than ablation to treat endometriomas, taking into account of the woman's desire for fertility and her ovarian reserve. Also, see ovarian reserve testing in the NICE guideline on fertility problems. Combination treatments also comes under surgical management. After laparoscopic excision or ablation of endometriosis, consider hormonal treatment with, for example, the combined oral contraceptive pill to prolong the benefits of surgery and manage symptoms. Hysterectomy may be indicated in combination with surgical management in cases of adenomyosis or heavy menstrual bleeding that has not responded to any other treatments. And you should excise all visible endometriotic lesions at the site of the hysterectomy. Perform the hysterectomy laparoscopically when combined with surgical treatment of endometriosis unless there are contraindications. For women thinking about having a hysterectomy, you should be discussing what a hysterectomy involves and when it may be needed, the possible benefits and risks, of having an oophorectomy at the same time, how a hysterectomy could affect endometriosis symptoms, that hysterectomy should be combined with excision of all visible endometriotic lesions, endometriosis recurrence and the possible need for further surgery, and the possible benefits and risks of hormone replacement therapy after hysterectomy with oophorectomy, which you should also look at the NICE guidelines for more information on. Many patients suffering from endometriosis prioritize fertility, and this should be taken into account when it comes to surgical management of their condition. So offer excision or ablation of endometriosis plus adhesiolysis for endometriosis not involving the bowel, bladder or ureter, because this improves the chances of spontaneous pregnancy. Offer laparoscopic ovarian cystectomy with excision of the cyst wall to women with endometriomas, because this improves the chances of spontaneous pregnancy and reduces recurrence. Take into account the woman's ovarian reserve. Also see ovarian reserve testing in the NICE guidelines on fertility problems. You should discuss the benefits and risks of laparoscopic surgery as a treatment option for women who have deep endometriosis involving the bowel, bladder or ureter and who are trying to conceive, and this should be done working with a fertility specialist. So topics to discuss may include whether laparoscopic surgery may alter the chance of future pregnancy, the possible impacts on ovarian reserve, also see the ovarian reserve testing on the NICE guidelines on fertility problems, the possible impacts on fertility if complications arise, and alternatives to surgery, as well as other fertility factors that the patients may have questions on. Do not offer hormonal treatment to women with endometriosis who are trying to conceive, because it does not improve spontaneous pregnancy rates. Let's take a look at the endometriosis algorithm. This is published on the NICE guidelines for fertility, and you may take a look on the slides. Thank you for your time for listening to this presentation about endometriosis, and I hope you stay tuned for more videos in the future.